And I want to first foremost thank Global Health Council for bringing all of us together and inviting me to moderate this very important event today, and especially welcome all of you to our session on gender inclusive COVID-19 response and recovery. Really encourage all of you to engage with us as we are coming to wrap soon. Encourage you to use the chat function, share your comments, your ideas, and really pose questions so that our esteemed panelists can engage with you. We also encouraging you to use social media, use the hashtag GHLS2021, tag globalhealth.org, and let's keep this conversation dynamic. Just to kick us off, I wanted to introduce a little bit more about myself. I'm a practicing physician in the Washington, D.C. area, but I lead Women in Global Health, and we are a global movement that is challenging power and privilege for gender equity in health. We have over 40 chapters, including a really vibrant community here in DC, which Global Health Council is very engaged with, and we have over 50,000 supporters around the world in 40 chapters, and we continue to grow, and it's really a privilege to be able to be amongst such eminent speakers today to talk about an agenda that I am very personally committed to as a physician, but also as the Executive Director of Women in Global Health. We are joined today by speakers Victoria Rams. She's a Senior Associate in the Buy-in Global Center and Youth Practice with over 25 years of experience managing and implementing cross-cutting programs related to gender equality, women's empowerment. She also is the Chief of Party for USAID's Gender Integration Technical Assistance 2 Task Order, what a name. But want to highlight that through this work, there has been at least 11 different COVID-19 gender analysis developed during this time. So really looking forward to hearing from Victoria soon. We have Riaz Mobrokali from Mozambique Pathfinder, who is a proven leader in public health with over 13 years of experience in management implementation at the national, provincial, and district level, with specific focus in sexually reproductive health, maternal neonatal health, and HIV and AIDS. And before joining Pathfinder, Riaz also spent 7 years with the Mozambique Ministry of Health. So it's great to have this additional government perspective too. And we're also joined by Dr. Stephanie Paskey, who is appointed Senior Advisor on Human Rights and Gender Equity in the Office of Global Affairs in March 2021. Before joining HHS, Dr. Paskey was the Director of the Population Council's Girl Innovation Research and Learning Center, which provides guidance to governments, international organizations, philanthropies on investing resources and expanding opportunities for women and girls. She also has a very extensive research and prolific academic background as well. And finally, not least, is Dr. Julieta Onabanju, who's the Director of UNFPA's Technical Division. She's a national of the US and Nigeria, and Dr. Julieta took up this position in August 2021, bringing to the role over 24 years of experience in programming, management, development, advocacy, partnerships, and leadership with UNFPA, and she has extensive experience working at the country and regional level. Again, what a enriching panel. So to kick us off, I've actually been tasked to set the scene, and there's so much to discuss on a topic such as gender responsiveness during the pandemic and in pandemics in general. And we've been hearing throughout the Landscape Symposium how critical it is to have equity and how equity is essential to health security. And if we don't have equity in our health systems, we are not going to have health security. So building on the theme, we're going to be doing a deeper dive into what is gender responsiveness, why is it important, and how can governments include gender in their health policies and strategies? And isn't it great? We're joined by experts who are working with the government, in the government, as partners. And so now as I set the scene for the discussion, it's just still astonishing that we're almost 2 years into this global pandemic. And like many of you, I too had imagined this would be for a few weeks or a few months, but now, our global pandemic is a part of everyday reality, creating uncertainty. And COVID-19 has exposed the dark truth of the deep social, economic, and political inequalities that drive ill health and pandemics, both within and between countries. And a big part of that is the gender inequality, which is a fundamental part of that picture. We also have been hearing throughout the summit is that COVID-19 does not discriminate, but humans beings do. Societies discriminate. The rich have been the first to access vaccines, while even health workers remain unvaccinated in low income countries. As a health worker myself, I've been privileged to be in a country where I was able to get the vaccine days within it getting approved. And now, I've also received the third booster, and it is quite controversial where many of my colleagues all around the world have not even received the first dose of the vaccine. So it just shows you the gross inequity. And we've talked a lot about the themes of global solidarity in this symposium as well. But global health security seems an improbable ambition when at least half of the world's people lack full coverage for essential services, especially with marginalized groups, women and girls are even further behind. Next week, it's going to be, or actually on this weekend, it's going to be Universal Health Coverage Day, December 12th. And Women in Global Health will be launching our campaign for the 2023 UN high-level meeting, championing for gender responsive universal coverage. And this is exactly the core part of our call to action in health security is being gender responsive in our health systems. And the only way that health services will reach everyone equitably is if we address and champion all genders. Right now, universal health coverage remains a distant dream for billions and puts further everyone at risk. And as I hope many of you tuned into the opening keynote for today, where Dr. Gadai talked about the linkage between universal health coverage and health security, and societies that have universal coverage are going to have greater health security. And then kind of moving forward, the pandemic has also exposed the fundamental inequalities that we must put right to build global health security. Global health security is not a broken system, but it was built unequal. And there's many examples of this. And the ones I'd like to really highlight are focused on the role that women have in health systems. For example, women deliver health services while men make majority of those decisions. And again, I'll say that women deliver health services while men lead in health systems. Women's unpaid work forms the foundation of health systems. It's estimated that half of what women do in the health sector remains unpaid, and that is about 1.5 trillion US dollars annually. And I can let you know that these numbers are increasing during the pandemic. Women are 70% of the healthcare workers, only hold 25% of decision-making roles. And in COVID-19, that has been demonstrated again, with 85% of the national COVID-19 task forces being majority male membership. And there have been entire task teams that are all male, even when there's been dozens of seats. So it shows you that, again, our system is set up to be unequal. We've lost out on the expertise of women. And when we lose out on that expertise, it actually creates weaker health systems. COVID-19 threatens to have inequality wider than before, especially between women and men. And if we add an intersectional view to this, especially between different groups marginalized by race, disability, age, caste, sexual orientation, migrant status, gender identity, and depending on the social context, they're further marginalized. And as my vantage point as a practicing physician who's been taking a global view with women in global health, I want to finally conclude with 3 points on gender equality and global health security. First, this pandemic, and in normal times, women are already the social shock absorbers. But in a crisis, especially, they are the shock absorbers for their families, communities, and societies. It is women in this pandemic who have borne the increased burden of unpaid work, intimate partner violence. I'm symbolically wearing orange to signify the 16 days of activism calling for an end to gender-based violence. And it is the girls of the poorest families who have been taken out of school and forced into early marriages when families needed one less mouth to feed. And we're losing generations of girls that may not ever recover from this. Second, when women are marginalized in health leadership, decisions that ignore the realities of women's lives cause lasting harm and death. So this is not only about the right thing to do, it's not only about having the smart thing to do, but we are losing lives when we don't have women in decision-making roles. An example of this is 1/3 of the countries in a WHO survey reported disruptions to maternity services in the pandemic. And we know that women know that pregnancy does not stop for pandemics. And actually, everyone in society should know that. But we've seen decision bodies, again, not considering access to maternal services as essential services during COVID-19. And we've seen this especially with our midwives calling out the issues of task shifting that they have been forced to do and cut essential services. Women and adolescent girls have died from these disruptions. And again, these are not new things. We have seen this in the Ebola outbreaks, but the pattern is repeating itself. And finally, women as majority of health and care workers have been applauded for their contributions in the pandemic. We've heard from many health workers in the symposium, community health workers especially. Many of them are women. They're clustered into lower status jobs, lower paid jobs. They face violence and harassment. And the gender pay gap in the health sector is about 28%, which is much higher than many other sectors. And I've already talked about that half of what women contribute, 1.5 trillion, is in the form of unpaid work. So just really pervasive inequities. And women have been sent out to the front lines. They haven't had access to personal protective equipment. The PPE has been designed for male bodies. It's exposed them to infections. Health workers in many countries remain unvaccinated, and health workers have died, and and millions have been infected. So they are also dealing with long COVID. And after 2 years, health workers, particularly women, are burnt out and exhausted. And we are estimating significant numbers of nurses, midwives, in high and middle income countries planning to leave the profession. We call this the Great Resignation of women health workers, and this is really a red flag for future global health security. The pandemic has already started with a massive shortage of 18 million health workers to achieve universal health coverage, and we cannot afford to lose even one single health worker, but we are losing the health workers. And so, as we think about really creating and achieving the health security agenda and having stronger health systems and achieving universal health coverage, we must really call for a new social contract, especially for women in the health and care sector, giving them decent work, safety, dignity, fair pay, and equal leadership so women can do their jobs better and deliver stronger health outcomes as they'd like to. And by definition, global health security must be built on equity with gender equity at its heart. So as I've set the scene, I know I'm still missing so much of what it truly means to be gender responsive. And I turn to my panelists now to really help us go deeper, really understand, what are the examples of being gender responsive, and especially how is gender responsiveness in the context of global health security. So I'm going to first turn to Victoria to kick us off. How would you define gender responsiveness in the context of global health security?
Thank you very, very, very much, Rupa, and to esteemed panelists. At the most basic level, I think we're looking at health systems and services that, to touch on what other panelists have mentioned in earlier sessions, ensuring safe and equitable, and I do emphasize the word equitable, access to and use of services for women and girls, men and boys, LGBTQI persons, especially those who are from historically and traditionally and currently marginalized groups in terms of sexual and reproductive health, family planning, GBV prevention and post-GBV gender-based violence care, HIV case finding and continuity of treatment, and of course, the COVID-19 vaccine, as you mentioned, Rupa. I think, again, building on other earlier sessions, the question of compounding vulnerabilities as well as strengths is I do think we need to focus on strengths as they relate to use and access and use of those services, in particular, persons of specific ethnic groups, disability status, sexual orientation, and gender identity. And then taking that into data collection, analysis, use of the data and monitoring and evaluation in terms of sex, but also, again, other variables, these key variables related to ethnicity, related to disability status, migrant status, and then building that forward in terms of gender responsiveness, health strategies and planning, not only at the national level, but also decentralized and deconcentrated levels of governance in terms of COVID-19 strategies and plans and budget allocations. Building upon the last session that I attended, is human and people-centered policies and care, and really thinking about systems approaches and bundled and integrated policy measures, is that humans are at the center of all of this. So considering the fiscal, the labor market, the education policies and plans, and how all of them come together, how the sum of the parts can be greater than one, not only to address vulnerabilities and health vulnerabilities, but also strengths. And within that context, going back to what you said just a moment ago, Rupa, women's care burden, women's role in the informal economy, education levels, at the household level, unequal decision-making and access to resources, and the impacts on economic security, and connecting those dots not only in health systems and health policy, but also across multiple policies. Finally, really thinking that a lot of the norms and access to resources, those that are gender unequal, predated the pandemic, but considering how they're evolving during the pandemic, what has changed, and how does that change access and youth to use of health services, and also finally, on the topic of innovation and gender responsive innovation, is there has been so much innovation during the pandemic, building upon lessons learned from the Ebola pandemic, from the from experience with Zika, is really how do we generate evidence, take stock of the evidence on innovation, and scale that up in terms of gender responsive design, be it telehealth, telemedicine, localizing services, task shifting among healthcare workers. So that's just sort of to kick us off, but really looking forward to hearing from the other panelists as well. Thank you.
Thank you, Victoria. So I'd like to turn to Riaz to chime in. How do you define gender responsiveness in your context?
Thank you, Rupa and everyone. First of all, let me thank you all for inviting us to really have this opportunity to talk and to share our perspective on the gender responsive healthcare services, health systems. So I'll first start talking in 3 key points how we define gender, because I think this is for us a starting point. One, I think it's very important to assume that gender is distinct concept and not the same as sex. So because sex classification is what we typically assign at birth. But then the second point that is important is that this gender is socially and culturally constructed, and our understanding and changes across the time and context as well. The third aspect that I want to flag in here is that it also refers to roles, responsibilities, characteristics, and behaviors that a given society associates with our identity as woman, girl, boy, man, or non-binary. So I think this is like the framework. So we are clearly set on what we are talking whenever we talk about gender. And this is the definition that Pathfinder has on gender. So with that said, I'll say that, and not going really away from Rupa, what you said in the beginning, gender is a very important social determinant of health. So with that said, only a health system that considers all and is sensitive to gender differences and inequalities that you mentioned before, and Victoria also said about that in multisectoral and different aspects and variables that we should be entailing and engaging. And if all those are addressed, then we have I still say more a system that is more prone to provide equitable and universal gender-centered services. And when we say that, we are saying that in multisectoral and intersectional in a way that we should be seeing and considering variables such as age, rural, urban, race, ethnicity, socioeconomic status, literacy, because it's not one model fits all. So as much as we are able to adapt and tailor ourselves to specificities, we are better to go, as Victoria was talking about, human-centered approach, and gender is not disconnected to that. Thank you.
Thank you, Riaz, for that. And really comes out quite strongly how much the relationship between gender is linked to societies and perceptions, and how that is a dynamic aspect, but also how gender is an entry point. And Victoria, you also talked about the intersectionality aspect in your response and linking it to data and also contextualizing it. So I turn to you next, Stephanie. How do you define gender responsiveness, and just adding a little bit of a challenge in the sense that the U.S. government particularly is a leader in global health security, but how do you see gender responsiveness in the context of global health security?
Thanks, Rupa. And it's hard to follow on to the first two panelists on this question, but hopefully we can keep moving it forward and deeper. So yeah, from the perspective of the US government, I think President Biden, was very clear at the outset of the administration that responding to COVID is, the top priority, remains a top priority for the US government. And I think we all, as Rupa mentioned in the beginning, we're hoping that we would be in a different place as a world than where we are now, going into the third year of this pandemic. So that will continue to be a top priority. President Biden has also stated that advancing gender equity and equality around the world is a top priority. And I think we've made enormous progress on both of those issues sort of in parallel. And one of the reflections as we look toward the second year of the administration is that we need to now continue to integrate our work on these issues. So as we think about the global health security architecture globally, as we continue the COVID response and recovery, and we advance these goals around gender equity and equality, these are not separate issues, these are the same issues. So that's kind of a fundamental, I think, challenge and opportunity for all of us. In terms of gender responsiveness within global health security, I will say something that I'm sure all of the panelists agree with. There's no such thing as a gender neutral policy, period. So we always have this conversation about, is this one of those health areas where gender is relevant? I think that's sometimes how the conversation is framed. It's always relevant. And the question is whether we are going to be proactive and thoughtful about the way gender is integrated, or it's going to be integrated by default. I think in terms of global health security, the core question we need to ask is, whose security are we protecting? And the answer can be more than one group, but for example, when we mobilize resources around the world to respond to an Ebola outbreak in DRC, for example, is the goal primarily to prevent Ebola from spreading outside of DRC, or is the goal primarily to protect the health and security and well-being of the populations in those communities, or is the goal both? And I think our answer to that question is going to drive how our policies are formulated fundamentally from an equity perspective. I will pause there because I think there have been some great answers, and excited to get to the next question.
Great to hear that point, Stephanie, that there's no such thing as a gender neutral policy. And I think we will carry that with us. So turning to Julieta, to get your take, especially bringing the UN perspective into this question of what does it mean to be gender responsive?
I think first, just to say thank you. It's really an honor to join you, and on behalf of Dr. Natalia Kanem and Dr. Cater, who are going to really engage with you on this special Human Rights Day, to really hear the conversation and to be part of the conversation. So thank you, Rupa. I think you set us off, and all the other colleagues have really provided the perspectives. I'm not sure what else to add at this stage, but I do think, what we are trying to see is this is an opportunity in time to even go beyond just a responsive framing, because I think it is important, and we've talked about the inequities, etc. But to have a transformative framing, and so almost a gender transformative approach to the way we think. And what that I feel allows us to do, and I think, Stephanie, you spoke about this gender neutral nothing is, but is to really look for opportunities to even push it further in terms of creating, I think, a global architecture and system that allows us opportunities to empower, to position, to really address some of those real drivers, a bit like what Riaz said, the fundamental drivers, whether it's privilege, whether it's power, and really challenge the system to a different place. And in a way, I feel that if we can move to that sort of conversation at this particular time, we will do even much more justice for the next set of things that we have to face. So agreeing to everybody's sort of perspective that's been brought, but to really challenge it to a gender transformative approach to how we see this. And of course, fundamental, as we celebrate Human Rights Day, is really to again center it in the human rights of all and the intersectionality of all human rights, and particularly for us, sexual and reproductive health and rights and women's rights. Because I think if we continue to think human rights based approaches to the way we do that, we don't lose in any way. And Riaz spoke to gender, the binary gender. And I think we are at a space where we really, if we center it around the human rights of all individual persons to health, that we begin to also allow for other gender types that I think will continue to evolve as the world. And I know I've just come off one where young human rights defenders were telling me, you guys are still needing to understand us in a different way and where we're at. So for the generation that comes, I think we'll be in a better space. But really, maybe just to add that perspective at this stage.
Thank you, Julieta. And I already like how our conversation is going into the root drivers of these gender inequities and looking at power relations and the dynamic aspect and how we need to continue to evolve. I'd like to turn actually back to Riaz and then Victoria, because the next question, usually we begin with a lot of success stories because that's what's, what we like to do in Global Health is talk about the success. But, stepping back, we've defined gender responsiveness. I think a good working definition of it where we've talked about that gender is intersectionality, social construct, gender roles, all these different aspects of it. But, what we're still seeing is that the pandemic continues to be gender blind. When we've Women in Global Health and many of our other research partners in this space have looked at global fora discussions, gender is rarely mentioned. And if it is mentioned, it's really part of the actual COVID-19 response plan. And if it is part of the response plan, there aren't resources allocated to it. But as both of you are coming from the civil society NGO background, beginning with Riaz, what are some recent examples of outcomes that you have seen because of this failure, because we are failing to truly, have a gender responsiveness in our pandemic?
Thank you, Wrapup. It is. I'll start by saying that sometimes we fail when we do not consider, when we fail to consider the restrictive social and gender norm that limits access to health services, as well as when we also do not consider the inequalities in using social spaces. We start to fail frequently, and the pandemic was not an exception when we fail to consider these two aspects, how the context, how everything around us influences the gender dynamics. So when we talk about voice, agency, empowerment, how all this affects the decision-making and access to services. That's one. And then COVID, when COVID, you clearly said we are going to the third year in Mozambique. We started in March. We had the first case reported in March 23rd in 2020. And then COVID somehow shown what inequities were, but somehow even worsened the inequities in access. And I'll pick three examples. Otherwise, it's a long list that we will take the whole day here. First, I think one is the limitation with COVID. We had schools closed, right? That's I think happened everywhere in many countries. With school closure, limited access to sexual and reproductive health services, particularly for adolescent and youth. From one hand, that's what we saw in Mozambique. So the adolescent girls, boys, they couldn't get the services that they used to have on their way to schools or in outreach teams and all that. That's one layer of challenge that we faced. But the second was, as I did mention, on the gender empowerment voice agency, as many of the women doesn't have their support also from the partner or on contraceptive users, as Victoria was talking about family planning, for example. Many of them using some of the most common method in Mozambique is injectable, with a method mix which is higher than 50%. Majority is using injectable. That requires a shot every 3 months. So on that one, women were and girls, they were not being able to go to the health facility because they didn't have that support. So that was one of clear example of limiting access, as we were not able to adapt immediately, like preparing outreach teams for areas close to the households and things like that. That's one. The second is going back to gender-based violence discussion and topic that I think Rupa, you mentioned, Victoria, you raised somehow, is one of the key aspects that we have been seeing in different interventions is networking between women and girls on the gender-based violence and support groups. COVID restrictions and confinement limited that and somehow triggered the increase of some GBV cases that we could see. And the third, as I think everyone is quite aware, in Mozambique, in the northern Mozambique, we also have some security issues. The insurgency that is happening in the north. Combination of that with the restrictions due to COVID and everything also somehow triggered an increase, I would say, in child early forced marriages, and those confinements, internally displaced population scenarios. Also, that's where I bring again the topic when I was talking that we should consider all aspects: rural, urban, humanitarian settings or not, age, and all those aspects that really requires our quick adaptations. And this is where we see clearly that we need to learn from the context and what is happening. I'll pause here, Victoria. Thank you, Rupa.
Yeah, Riaz, you really painted the picture that things are rarely simple. Realities are rarely simple, but they're quite complex and require systems thinking. And Victoria, in your work, you've done over a dozen analysis during COVID-19 of gender. What else are you seeing? What are some of the trends that you're finding of the failure and the impact of that failure?
No, thank you so much, Riaz and Rupa. And I also really want to acknowledge actually the work of CARE International and their very robust work doing COVID-specific gender analyses using their rapid gender analysis toolkit, upon which we built in the analyses that we did. So at the most basic level, we're looking at in terms of outcome, early pregnancy, unplanned pregnancy complications and complications after childbirth, increased exposure to HIV, a potential increased HIV viral loads, gender-specific worsening of mental health status, increased exposure to GBV, and inadequate post-GBV care services. So thank you, Riaz, in particular, for mentioning intimate partner violence and child and early and forced marriage. as well, directly within the health sector, the results of not putting in place gender responsive and, as Julieta mentioned, gender transformative measures, for example, among health workers, has resulted in healthcare workers obviously becoming infected with COVID-19, becoming burnt out physically and suffering disproportionately in terms of mental health, and not having access to, for example, childcare, which links to economic and health security, as well as actual health outcomes. And in terms of our own context in the United States, most of the health workforce being Black and women of color. So thinking about that disproportionate impact, including among my very own circle of friends here in New Jersey. When we think directly, immediately beyond the health sector, is not considering other related causal factors and what the outcome or the quote unquote failure is thinking about gender unequal intra-household decision making and access to resources, which Riaz alluded to, and how that affects access to healthcare facilities, payment for health services, purchasing medications, and of course actually using health services. Also, the issue of digital literacy and access as more services become remote, and women and girls traditionally and currently have lower levels of digital access and access. So thinking about that and how that can reinforce inequalities, in particular, for example, among rural women and girls of certain ethnic groups, and how that can impact health outcomes. Also, not taking into account this bigger picture of economic insecurity, the loss of income and jobs. In particular, women are the majority of informal workers, as are migrants globally, and how that can contribute to worsening health outcomes and inequitable access and use of services. The last I'd like to really, I'd like to mention is not considering unpaid care work and the obvious linkages both to health outcomes and how that in turn, worsening health outcomes can contribute to worsening economic insecurity and sort of that cycle and the interplay between the two of those factors. Lastly is not thinking big picture, dot connecting, bundling of services and policies is fiscal policy through expenditures and tax policies, and how they can have a negative impact on frontline workers, including women and men, the impact it can have on the protection of outcomes, including female health workers, and how fiscal policy can decrease or raise revenues even to finance gender responsive or gender transformative spending measures. So an example is family-based tax systems. So when taxes are determined at the household level, secondary earners, who are often women, face higher marginal tax rates compared to singles with the same characteristics, and that if they are the secondary earners and they are women tend not only to be responsible at some level for decision making about access and use of health services, not only for themselves, but for the whole entire household. So thinking about the larger social protection context that we heard about in one of the sessions that immediately preceded this. So thank you so much, and looking forward to hearing from the other panelists.
Yeah, Victoria, it's you really created that bridge between health and economic security, but also the linkages between health and well-being is a critical part of just having healthy societies and economies very much. And so, really prime examples, echoing a lot of what Riaz has said, but also going broader into other sectors. I'd like to actually turn to Julieta to also build on what's been said. UNFPA has been leading on some of the most robust research on letting us know, what the actual lives lost are in millions that we're seeing. And unfortunately, we are seeing those trends. And so, what failures from your perspective at UNFPA?
Thanks, Ropa. And I'll build on actually what already I think are some of the real, I think there's so many impacts that COVID has shown us in so many directions, but particularly for women. And in this conversation, and for us as a sexual and reproductive health agency, clearly the disruption of sexual and reproductive health services was extremely evident. We predicted, and so I think this notion of really being predictive as we think about where we go, and that element, because I feel that, you know, COVID, we messed up in many places, I feel, as a global community. One was to what extent were we really prepared for what we were going to be scaled up? For what extent did we have those early warnings? For what extent did we take note of those and, in a way, do a quick response? And I think these are lessons that we really do need to learn. So for us as SRHR, the minute we did sort of predictive projections with Avenir Health about what would a lockdown, for example, of 6 months mean to, you know, disruptions of services, whether it was sexual and reproductive health, antenatal care, but even just the whole spectrum of SRHR. So it was gynecological shutdowns, you know, those that were not considered essential. And indeed, in fact, initially in the first 3 months, the whole gamut of SRHR was considered non-essential. And until you brought to the policymaker the data and the evidence and the analysis that you spoke to, they began to then internalize, oops, we even have a much more serious problem. And so I think that is really, for us, was really important. And indeed, you know, it took a lot of advocacy with all partners to ensure that the health system, but also just the response, which actually moved outside of the health system to the highest political levels. In countries, it was the government, it was the president that was taking on this action, which in itself is good. But in a way, you had to orient a whole new set of players into thinking about this. On the school health, I really love that example, Riaz, because I think for us, we had anchored a lot of our work on the school system, on the educational system, particularly for young people, whether it was comprehensive sexuality education, whether it was menstrual health programs, whether it was school feeding programs. And so once that shut, the impact, particularly for young girls, was immense. And this is where we're seeing other precursors for things like child marriage, for things like teen pregnancy, for transactional sex, because of period poverty, and that economic piece that Victoria has spoken to. So we were very quick to again work within societies to really look at how can we shift a lot of those sorts of programs to out of school youth programs to still recognize young people as vulnerable in this pandemic and to take action. The third was around the gender-based violence. And of course, we locked our women into perpetrators in the home in that response. And I feel that we've really advanced in recognizing the challenges of gender-based violence in the home, intimate partner violence, to be able to look at other options for delivering that sort of response, whether it was helplines, whether it was really working, you know, door to door, knocking on to really assess that and the role of the health system. And then I think the fourth is the health worker one. And Roper, you said it right at the beginning, where the PPEs right for women. Did we have, you know, creches, the whole midwifery shift, you know? And I love Joe says we're going to have a recession of female health workers, 70% currently that way. But, you know, it really is the exposure that they had. And you know, I've heard health workers, and I'm sure you have, that say, you know, and particularly midwives, they say, we don't want to be superheroes in capes. What we want is a cape that will really protect us, will give us those opportunities, will give us really the right pay, the compensation, and that will actually protect us from disease. And so that exposure, I think we can't overemphasize the impact of that, but how we then, as we move forward, think about what we do.
Thank you, Julieta. And again, there's a lot of synergy coming in between the trends that we've seen in Mozambique, Riaz, and Victoria, and the work that you highlighted, both that you've done and at Cure and Julieta. So, really, it's quite clear where we're seeing these stress points. So I turn to you, Stephanie, to also just chime in from the position that you're in. And maybe priority setting, like which are the ones that you're really seeing the failures that we can't afford to ignore anymore?
Yeah, this is great food for thought. So I'm just thinking, I feel like a lot of the specific examples that I was going to raise have been raised in different ways, so I don't want to repeat them. But I do think as we start to move toward, okay, so what do we do about this now? Because I think we're in agreement that we haven't sufficiently addressed these connections. I think it's helpful for me at least to organize it in terms of different ways that gender comes into play. And so, and that's very consistent with what everyone is raising here today. So I think about it in a few different ways, and I'm curious if we're missing anything here from the audience or from the other panelists. So one is, of course, the direct effects of a pandemic or COVID, right? So we talked about, women's differential exposure to COVID as healthcare workers, and then in particular, this intersectionality issue. I know that the data are pretty stark in the US that even when you look at healthcare workers within this group of healthcare workers, as Victoria mentioned, there's higher levels of exposure and disease among Black and Brown women in particular. So there's these direct effects, and that's where the PPE issue comes in, which is hugely important and feels like such a concrete, obvious problem for us to solve here. And then there's kind of the indirect health effects. So we're talking about the disruption of sexual and reproductive health services in particular, and the fact that, somehow still these are not considered essential services as part of pandemic preparedness. And, maybe in theory, but not in practice, they fall off the agenda, even though we know that people continue to have sex, people continue to get pregnant, people continue to give birth throughout pandemics. And there's, broader, there's mental health effects, there's all sorts of other health effects, access to cardiac care, for example, in the US. And then there's these non-health effects that also have come up. So on the education system, disruption, there's a new estimate from the government of Uganda that 30% of students who were in school before COVID will never return to school. And that's disproportionately girls for the reasons that were raised earlier, child marriage, unplanned pregnancy. So these other generational effects that happen outside of the health system, also the economic disruptions. I think Riaz mentioned and Julieta mentioned as well, the SRH services provided through schools. But another type of service that's been disrupted is food provision through schools. And there's this huge increase in food insecurity. And then there's kind of, and thank you to Victoria for bringing this up, because I hadn't really thought about it this way, but these structural factors that are in place beyond these kind of direct effects. So what are the structures that are, in place before the pandemic occurs, but because of the way that the structure is set up, it leads to more inequity, and in particular, certain groups of people who are further marginalized. So I think within that framework of these kind of 4 levels, thinking about how our global health security response needs to address the ways that gender comes in within that framework. And I think that's maybe what we're going to talk about next. But did I miss anything there? Are there any other levels to the other panelists?
I think, Stephanie, that's a great framing, and I actually want to turn right back at you to answer the question you posed, which is also our next round of questions, is around how can governments and other stakeholders really ensure that we are being gender responsive in the pandemic response and recovery. And I want to encourage our those tuning in, our attendees, to please submit your questions and comments in the chat function. We are looking at that. But turning to you, Stephanie, to answer the question you also just put yourself out there with.
I was hoping someone else would answer. So yeah, I think I don't think that we have all the answers to this question. If we did, hopefully we would be doing a better job. But again, and kind of in the short term, I think we've talked about who is in the room in terms of decision making, and having more women in leadership roles and more diversity and representation more broadly in terms of the decision-making roles is hugely important and a place where we need to make progress. At the same time, it is true, I think we all know, that just because a woman is in charge doesn't mean that a response will be gender responsive, and that it's not the sole responsibility of women or other groups who are representing their populations to carry that burden. So I think the idea is that everyone who's in a leadership role should be trained, and the expectation should be that any response will be gender responsive. So that's kind of most immediately what is the conversation we're having in terms of decision making in the room. I think in the medium term, we want to build in, as we rethink some of these global health security structures, we want to build in processes, so build expertise when it comes to gender responsiveness and gender analysis, but also build in analyses that have to happen along the way in the systems. So we're in this moment where we're rethinking, what went wrong with COVID across the board in terms of our global health security system. And as we rethink that system, we need to build in gender responsiveness, so it's not left up to the people who are in the room. So for example, we're thinking about how we implement the recommendations from the independent panel for pandemic preparedness and response. We're working to update assessments and planning tools like the JEE. We're setting new goals and targets for 2022 in every step of the way, and this is kind of the mundane way that it plays out and will happen. We need to build in gender-related indicators and gender responsiveness. And the last thing I would say that in the long term, and I think other panelists have touched on some of these pieces as well, and this is really back to Victoria's point about the structures that we're operating in. We need to address those structures. So in the US, for example, we have to invest in a care economy so that when there is a crisis, whether it's in, at the household level, in the life of an individual, or a global pandemic, women do not need to leave the workforce if they don't want to leave the workforce because they don't have childcare or they don't have elder care or other support. That's a structural problem that existed before COVID and will persist after COVID unless we solve it. And I think this is just back to this issue as well of health systems strengthening. The most fundamental thing we can do is strengthen health systems before a pandemic occurs, make sure that there's equitable access to high quality services across the board, including sexual and reproductive health services, so that those systems are more resilient when a pandemic or a crisis occurs.
Thank you, Stephanie. I don't have much to add to this, as I want to make sure we hear from all of our panelists, and sort of a rapid lightning round of adding to what's been said there. I'd like to actually turn to Victoria and say, how can other stakeholders ensure gender responsive, and really pick your top one priority? What would you add to the list that Stephanie's already kicked us off with?
I think that most salient is really the issue of gender-based violence in terms of having all pandemic or other emergency response plans considering GBV prevention and response as mandatory, including updating GBV standard operating procedures, supply chains, commodities, etc. I also, again, just want to emphasize in the larger social protection context, considering innovations and measures on complementary measures on cash transfers, tax measures, flexible work arrangements, and access to paid family care and other labor market policies that can really complement the health system and improve health outcomes in a gender responsive and transformative manner.
Thank you, Victoria. Turning to you, Riaz.
Thank you. I wouldn't say one, at least three. The ones that
So, yes, please.
I'll quickly pick the ones that one. I think it's the investing in gender equality education from the earliest. So that's where we start to build the knowledge on gender across the future people that we are going to have around. So that's one very key. The second, I think it's very much linked with what we said before, is tailoring, adapting and tailoring different service delivery models when we are talking and thinking about sexual reproductive health, for example, and other services. Last one. I had six actually, but okay, last one. The last one is to address gender with an intersectional approach, as we have been talking all the time. It's not like one model fits all, but yes, we have to consider all those variables that we talked about: age, area, like urban, rural, ethnicity, socioeconomic, literacy, all the ones that we mentioned before. Thank you.
Thank you, Reyes, for those three. And then Julieta, close us out.
I mean, I think it's all said and done. I really enjoyed, and maybe, two things I'll say. One, I think, and definitely we must integrate SRH and gender-based violence within every, the movement, because I think unless we do that, we lose an opportunity again, not only to ensure and guarantee rights for all. That's number one. I really want to, really speak to the data piece. And I think, Victoria, the work that we're all trying to do, because I think that set us back. It took us scrambling even within, just the health facility data systems to disaggregate, to see where we're going, as Stephanie says, to see what was direct impact, what was indirect impact. And so real investment as we think about the future around that data analysis, the indicators. UNFPA is doing a lot of work with a number of data sources, whether it's censuses, CRVS, all that got disrupted, but then also real-time technology, monitoring SDG 5.6, and really trying to get government to say, know your data, know that as a basis and a foundation. And that needs to be gender disaggregated. It needs to be disaggregated by all the things we've talked about in terms of variables. So I think that's going to be really key. The investment in movements, feminist movements, in community groups that could really lead on and continue in that whole primary health care and the real community care that we need to really continuously invest in. The one opportunity I think we do have as a collective, and we're really trying to, has been actually just the recent decision under the World Health Assembly to begin a process to look at a pandemic treaty, to look at how this global solidarity really means what it says in terms of how we prepare and get ready for pandemics, global pandemics of a nature. And so I think this is an opportunity to begin to influence what we want to see in that resilience, as Stephanie spoke about, in that gender transformative ways, and really just getting it right and building it back better as we move forward. So sort of a medium, these processes take forever, but if we don't start, strategizing and being quite tactical as to how we get within those big intergovernmental processes, I think we then lose an opportunity. And just to reaffirm UNFPA's commitment to this, and lovely to meet all of you.
Thank you, Julieta. Just really, again, great wrap up. I have the challenge to bring this all together, but fortunately, I only have to do it in a minute. So really, this is just the tip of the iceberg. What we've talked about, some of those key messages. There's no such thing as a gender neutral policy. We're either gender blind, exploitative, or we're going to actually become gender responsive and transformative, really moving to a transformative framing, pushing further, being dynamic, and realizing how the process is constantly evolving. And yet, we've also talked a lot about failures, which we are often afraid to do in global health and development. And it was great to see the candid reflections from at all levels, at the country level, regional, global level. And when we continue to be gender blind, it actually is resulting in lives being lost, futures being lost. And we have those really hard-hitting examples from gender-based violence, child marriage, health worker burnout, and I could go on and on because there's so many of them. And that's why it makes it so hard to prioritize, because it really does require a comprehensive approach. And as we transitioned into how do we change this, who's in the room matters, but also the mindset of everyone who is in the room, regardless of the gender, everyone being gender responsive responsive, and really even bringing that intersectionality lens. Strong call for data. We've heard it often: what doesn't get measured doesn't get addressed, doesn't get done, but also making sure that this data is useful and it's intersectional. We talked about addressing structural barriers, and not just looking at the health sector as a standalone, but how it's interconnected to other sectors. And prioritizing is very difficult. As we've heard, there's so many issues that need to be addressed. So shifting our mindset to also be much more systems based, and building in resilience into our health systems, but also in our society. And it was great to hear the call for investment, particularly the investment into women's movements and organizations, and women's feminist movements that have been really critical to building resilience in their societies. But we also need investment for the gender responsive work that we're calling for. And finally, there are opportunities to take this discussion today that we're having at the Global Health Landscape Symposium, continue to build it in other global forums, contribute to global governance discussions, especially the one that was mentioned on the pandemic treaty, but encourage all of you to stay engaged at all levels, at the local level and at the global level, so we really do change the narrative and become gender responsive and transformative. Again, thank you to Global Health Council. Thank you to all the panelists for just really coming in with such deep insights. And I'm going to turn it over to our host, Eliana. The floor is yours.
Thank you so much, Rupa, and to all of the amazing panelists. This was a spectacular session. Just a few housekeeping. So we are going into a break now. There will be a break from 11 to 11:15. And then from 11:15 to noon, you can actually go into the networking / speed dating session that Elisha mentioned early this morning, which is really exciting and fun. And you can get some one-on-one with the participants through that session. So I highly encourage people to join the networking session. And then we will go into lunch from noon to 1 p.m. Our final keynote speaker and closing plenary will start at 1 p.m. Eastern Standard Time. Since there were questions about this in the chat during lunch, we will be replaying the recordings from the concurrent sessions for today. So if you want to listen to the recording for concurrent session A that was happening at the same time, you are welcome to do that. There is also a replay tab on the event platform where you can actually listen to past keynotes and concurrent sessions from yesterday as well. So enjoy the rest of the event, and I hope to see you all in the networking and then later on in the plenary. Thank you again to the panel.